The hemostasis is since centuries is a target how to stop bleeding. In the ancient Egyptians, they used natural things like fresh meat, linen strips as the mummies, and grease and honey to stop bleeding. And there are some drawings in the Egyptian tombs. There are some sort of primitive surgical clamps. And the Greek cemetery, you can find, they found a surgical set made of bronze and contains of something like surgical clamps. Ancient India, a physician called Sushruta, also he used some sort of ligature of using some plant fibers to ligate vessels. And at that time he advised that cautery can be used, or boiling oil to stop bleeding. The ancient Greece also, the surgeon, they made some sort of a mixture from different kind of materials can be applied on a bleeding wounds. Hippocrates, he used coldness to arrest bleeding. In the 2nd century, Rufus introduced compression again, artery twisting, and ligature. Of course, everybody knows Abul Qasim of Cordus. The Abul Qasim, or Abul Qasim al-Zahrawi, he's considered the father of modern surgery, and he has his book, Kitab At-Tasrif, an encyclopedia of 30 volumes. He's also described how to arrest bleeding, how to stop it, and invented a lot of the surgical kind of procedures and clamps. So in general, my talk will concentrate on the how to stop bleeding in a difficult areas, in a critical areas, and using hemostatic agents or materials. In general, that everybody knows about the coagulation cascade components. The platelets activation is one of them. And then later on, after the vessel injury, the platelets activation will start, and aggregation to the injured area, and then more further aggregation of the platelets, and then triggering of the vasoconstriction and the and coagulation cascade, all of it, until the formation of the stable clot. So in the traditional techniques, as I said from the beginning, and anciently, that compression, cautery, ligature, twisting, whatever, sometimes they used sort of material. So those are the traditional techniques, and still we cannot compromise it. The conventional techniques to stop bleeding is very important. Mechanical, you can pack, you can use pressure, and ligatures. So those, we cannot compromise it. This are very important techniques to abort bleeding. Pharmacological, systematic, all local. You can give recombinant factor 7 or erythropoietin material, synthetic erythropoietin, or you can inject epinephrine locally to slow down the bleeding. The blood products, whole blood, fresh frozen plasma, and cryoprecipitates and platelets according to the indication. And then surgical cauterization. Surgical cauterization, either the electrical cauterization or the other energies like the argon, the ultrasonic kind of energy to stop bleeding. What are hemostats available technologies? The factors influencing bleeding site and influencing me what shall I use? Do the traditional way, conventional way of stopping the bleeding, or I should start to think about the hemostatic material. Size of the operative field, one of them, how big is it, how narrow it is, and the intensity of bleeding, of course, the accessibility of bleeding site, and characteristic of the fluids because of the blood or urine or even air. You can seal it with the sealants rather than to be hemostatic agents, and the tissue type. The products, it has either the mechanism of action ranging between a passive way of action that invites and encourages platelet aggregation, or active if it is combined with thrombin, for example. If you add a thrombin, so it will be an active. So sometimes combined effects, the passive and the active effect together. And the format of those products could be fabric, could be flowable, like paste-like structure, liquid, dripping or spray, or sponge. So the functional attributes to if they say that what is the ideal hemostatic agent, it has to be easy to use, adherent, strong, speed of activity, durability, and covers a good area of a bleeding site if there is that bleeding site is large enough, and safe, and degrade, and safe to the tissues itself. So those are factors influencing the types of hemostatic agents, and in the same time, what shall I use according to the site of bleeding. So an overview of the topical hemostats and surgical sealants technologies. There are different types. There are types which is called oxidized regenerated cellulose-based hemostats, gelatin-based hemostats, collagen-based hemostat, flowable hemostat, fibrin sealants, and combinations and synthetic sealants. The oxidized regenerated cellulose, this is produced through what is called rayon. Rayon is a regenerated cellulose. And what is rayon? It is not natural and it is not artificial. It is not artificial in the base that it is derived from natural source occurring in cellulose. And at the same time, it is not natural because cellulose itself requires extensive processing to become rayon. So rayon, it is a fabric. And that fabric is classified as regenerated cellulose, and it is in use since 1880s in France for fashion and making clothes, and developed as a cheap alternative of silk. So we are using what we are wearing, indeed. That oxidized regenerated cellulose has two kinds of mechanisms, and function. First, the gelatinous matrix, which is formed by the platelet aggregation, invites more platelet aggregation until the binds to the fibrinogen, and that fibrinogen platelets complex will form the soft plug. The vasoconstriction effect, because of the cellulose, when it touches the blood, converted to cellulosic acid, and this has a vasoconstriction effect to the vessels, and this will slow down also the bleeding. And in addition, that has some lower the pH and has some sort of antibacterial activity. This is when it can be left in the body and reabsorbed by the body within 7 to 12 days. The gelatin-based hemostat, made from animal-derived purified gelatin and processed into a foam and dried and then sterilized. It absorbs amount of fluid more than anything else, swells indeed, and can cause of a local compression to the bleeding wound. So the blood flow will be reduced. Also, at the same time, that matrix of gelatinous foam will invite platelets aggregation and fibrin clot formation. That one broken down and absorbed by the body in 4 to 6 weeks. The collagen-based hemostat, it's highly purified collagen from animal-derived dermal or tendon sources, then the freeze-dried and then frozen and then dehydrated at low temperature, so to form what is called microfibrillant collagen. These large helical structures with its large surface area will invite a bigger amount of platelet aggregation. So this is more faster than the oxidized regenerated cellulose to achieve hemostasis. And sometimes it is combined with thrombin, so it will also reach faster and more effective in hemostasis. This can be broken down and absorbed by the body within 8 to 12 weeks. Flowable hemostats is animal-derived gelatin in a pre-filled syringe. It can be mixed with a saline or a thrombin and also produce foam-like structure, and because of its swells and can be combined with a thrombin, so it is a sort of a hemostat can be combined through the compression to the bleeding vessel or bleeding area and a mechanism of thrombin itself. So they converts fibrinogen to fibrin to a stable clot around the mechanical matrix of that hemostat. It's fast, considered to be fast, because the hemostatic action within 2 minutes and reabsorbed in 4 to 5 weeks. Fibrin sealants has 2 components. They are solutions of concentrated fibrinogen and factor VIII, and they are combined in a solution of thrombin and calcium to stimulate final stage of cascade, the stable clot. And the final blood clot is absorbed in the same way of the natural clot happens in the hemostatic cascade. Those are combination, as I said, they can combine the mechanical way of the hemostat, the gelatin, the collagen, the oxidized regenerated cellulose, and the biological effect of clotting factors. Synthetic sealants, they are the surgical glues. Later on, I will discuss about tell you about what are different types. That surgical glues produced using 3 kind of in the market, either polyethylene glycol polymerase and albumin cross-linked with glutaraldehyde and cyanoacrylates. all of them almost the same, except that in the albumin cross-linked with glutaldehyde is a bovine serum albumin, and vascular surgeons, they like it after doing critical anastomosis, so they like to put it on top of the anastomosis as a vascular sealing of large vessels. And it is that one, the first generation of this material cannot be absorbed by the body, but later on the second generation can be absorbed within 24 to 36 months. So what are the Surgicel family? And we know about it. Surgicel family is what is called oxidized regenerated cellulose. The Surgicel original, the Surgicel NU-KNIT, which is listed in the market, and Surgicel FIBRILLAR, and the Surgicel SNOW. And they have different applications. They are the same, what is called the group of oxidized regenerated cellulose. The invites platelet aggregation and can be converted to cellulosic acid to have a vasoconstriction and sort of an antibacterial effect because of the low pH. So, and the hemostats can be achieved within 8 minutes of application, and it is absorbed within 7 to 14 days. Can cause some sort of minimal tissue reaction. They are the Fantastic Four indeed. So this is the Surgicel original. Everybody knows about it. And this is the FIBRILLAR. FIBRILLAR, the nice thing of FIBRILLAR that you can peel it one piece, you can use out of it 7 layers. So you can take one layer and another layer and another layer until you achieve a hemostasis. The nice thing of FIBRILLAR that you can make it in a way that different ways. You can make it like peanuts. You can use it as a strips. You can use it as a fluffy kind of thing. And then Surgicel NU-KNIT. Surgicel NU-KNIT is exactly like Surgicel itself, the original. The difference is more thicker, is almost 30% thicker than the Surgicel itself, and stands the fluids, and you can suture it on top of the area that you want to stop bleeding. It is good for after resection of a liver or partial resection of the spleen, and that area you want to cover to the hemostatic agent, so you can wrap that area with the NU-KNIT and have a stitch on top of it. Also, this can be used in laparoscopically, but the FIBRILLAR is not convenient for laparoscopic use. The FIBRILLAR, whenever you start to roll it and put it through the trocar, start to be sticky. So it's not an ideal for laparoscopic procedures. The last one is the SNOW, surgical SNOW. That one is similar to the FIBRILLAR, the only thing that is non-woven, and can be used in this laparoscopic procedures. The other thing that it is one layer. You cannot produce from it several layers. The antibacterial effect of cellulose when it is transferred into cellulosic acid, lowering the pH. There are some studies in vitro indeed, so they said that it really has some antibacterial effect. The other flowable hemostat, which is SURGIFLO Hemostatic matrix, This is a pre-moistured porcine gelatin powder, and this is ready to be mixed in a saline. You can just mix it with a 2 to 5 milliliter of saline, and it is ready to be used in 30 seconds. Has two kind of applicator, straight one or bendable one, the flexible one. The flexible one has a memory. Once you flex it in a way so it stays in the same way that you bend it. And it's suitable for the hard to reach really areas. So this is how it looks like. You can see the straight one. This is the straight, and it has standard length, but you can shorten it according your need. The SURGIFLO, the other tip, which is bendable, and it stays in the same way that you bend it. TachoSil. TachoSil is a collagen sponge, thick, and with human ready. It is ready made with human coagulation factor, fibrinogen, and thrombin, and it is manufactured from horse tendons. Reacts with the blood and other body fluids and saline, for example, to form the clot and glues to the tissue surface. The hemostasis is achieved in a few minutes, and the sponge is absorbed within several weeks. But some patients may experience some sort of hypersensitivity or allergic reactions and can be severe enough. So it is not indicated in patients with allergic reaction to horse. Why we should use hemostats in general? The diffuse bleeding from a broad surface area, it will not let me know where is the site, pinpoint site of bleeding. This one thing. The bleeding from isolated source carries risk of injury if I will just do what is called blind kind of suturing or clipping. So if the area is poorly visualized and I am near to what is called a critical area using a cautery or whatever and suturing in a blind or clipping in a blind way, this can give you a risk of damage and injuries to important structures. So use of ligature sometimes inappropriate. So what you will need, and sometimes it is using the suture itself, even if it is appropriate, it's time consuming because it is a labor kind of work. So the hemostatic agents, maybe it is convenient to use and to give you a time, better time and visualization of the field. Thermal methods, also even if it is indicated in that area, it will leave if you are using it extensively, can cause burn necrosis, and this and later on can increase risk of infection. Biosurgery of hemostasis with workshops we are conducting in the experimental surgery unit, and usually we train in big animals how to use these kind of structures when you bleed the liver, the spleen, or do surgical anastomosis of the between two vessels or large vessels, and on site we can use these sealants or hemostatic agents. It is very important. Surgical training is important for any kind of procedures. And thank you very much. This is my friend Dr. Muhammad Abu Hilal. He's consultant hepatopancreatic biliary surgeon. He was a guest speaker from Britain, Southampton University. He was very kind to help me in that workshop.